Thank you, Dr. Panda and Dr. Vanti, for inviting me to be part of this wonderful course. So I'll just continue from where Dr. Vanti left off and talk about some more advanced scenarios of deep lamellar keratoplasty. When we say advanced scenarios, basically we are talking about either tooth-thinned corneas, very advanced ectasias, corneas which are thin in the periphery where a big bubble, type 1 bubble will not reach, such as these. This is the advanced pellucid. Advanced infectious keratitis like this acanthamoeba, or deep scars. So deep scars again are a challenge for deep lamellar keratoplasty because you can't really get a big bubble safely there. You can end up rupturing the Descemet's membrane if the scar is involving the Descemet's membrane, or even a post-hydrops case. So advanced ectasia means it's either too thin or too ectatic or too large area of ectasia. Whenever you are assessing such a patient with an advanced ectasia, you want to see the size and location of the pathology. You want to see how deep the scarring is and whether it is touching the Descemet's membrane, because this may indicate that there is some kind of an old hydrops, and such a case there is a high chance of perforation if you aim to do a descemetic DALC. So it might be a good idea to do a pre-descemetic DALC in such cases. If there is, if the ectasia is approximating the limbus, then you'll definitely have to do a manual technique. A big bubble won't really help in this area. It will help in the central cornea. And if it's a very advanced thinning, then sometimes the working space is very less, and it may not be very safe to introduce instruments in between the stromal layers, especially if you want to do a technique like the big bubble, and you may again have to resort to modifications. The OCT is a very valuable tool in the preoperative assessment when you want to do deep lamellar keratoplasty. It helps us assess the actual thickness of the stroma in the thinnest area, gives an idea of the extent of thinning and what is the pattern of thinning, which areas of the cornea really thinned out. And it helps you assess the deeper layers, especially the Descemet's membrane and the deep stroma, because if you have any irregularity in the Descemet's membrane like this, that means that probably this patient has had some kind of a hydrops or something, and you definitely want to avoid a descemetic DALC in such a case. So as shown by Dr. Vanti, big bubble is probably the most preferred technique because it gives you really nice bearing of the Duas layer and a clean interface, and that will allow for very good early visual rehabilitation. I'll run through these videos because they've already been shown. So you puncture the bubble after removing a lamella and cut out your quadrants, put in your button and suture it. So results are very good, but it's not very easy. It has its learning curve. You don't always get a bubble, and especially in advanced cases where you have deep scars or you have very thinned out corneas, a big bubble is often not possible. So in such cases, then we have to rely on the manual techniques. One of the ways to do manual is layer by layer open dissection, as was shown. What I prefer to do is what I call the groove and peel technique. So I create a circumferential a trephination mark and then do a circumferential dissection using a routine universal corneal scissor all around, and then once one round is complete, I go in a deeper plane as is shown in the second video. So just keep spiraling deeper and deeper with each pass, and at some point you will reach the Duas layer, which is a glassy kind of a membrane, and you can once you see it, you'll know what it is. So once you've exposed about 2 or 3 clock hours of that layer, that's actually adequate exposure, and then you can just grasp the central island of stroma and just pull it away from the layer, even in the areas which have not been dissected that deep. So that's the advantage. Once you find that potential space, all you need to do is use stretch forces which are distributed over a large surface area. So it becomes quite safe, and there's no need to put any sharp instrument there. All your dissection is done by stretch forces. As you can see, there will be some small fibrils attached left behind, but they don't really matter. And I've seen several cases now that the optical results and the visual results are comparable to what you would get with a big bubble. So even in these areas where we didn't really expose the Duas layer, you're able to just extend that plane of dissection just by pulling gently and giving a counter traction at the opposite side. So I can show you so many videos in which I've consistently been able to do this. So this technique has really helped me in these kind of advanced ectasias, and even if I'm dealing with a VIP case, this is probably the case which I would prefer rather than a big bubble, because it's more consistent in my hands. And you can see you get very good results. Even first post-operative day, you can see there's a small bubble. It's comparable to what you'd get with a big bubble. In keratoglobus, what I've seen is for some reason the stroma is not very well attached to the Duas layer or the desmes, and it really lifts off like a LASIK flap. If you really open up the interface with dissection, you see this video on the right, you can just peel it off like a LASIK flap. It opens very easily. So the attachments are very weak, and the plane at which it comes off, just take it off at that plane and put another large graft and suture it, and results are quite good. It's probably a good idea to do the tuck-in technique and tuck in the edges so that the approximation at the limbus is better. This is just a patient with keratoconus in which we are doing a femtosecond assisted talc. So the thing I'd like to highlight here is femtosecond laser is useful in talc, but don't use the femtosecond laser to create the interface. Use it for the sides. The advantage is it gives you a very good mushroom cut. Mushroom cut is better for stromal disease because you can remove more of the stroma and leave behind more of the healthy endothelium. Second is you get a very good approximation because you get a perfect fit. And the third thing is you can be very sure that your deepest point is 100 microns or so away from the desmes. So you know where you are, unlike in a trifine. So once you're in that depth, you use any instrument. Here we are using a pointed dissector to kind of just create a little channel, and then through that channel introducing a big bubble cannula. And I'll just like to show you, when you're introducing the big bubble cannula, initially you'll feel some resistance, but the moment you reach the pre-Duas layer space, you'll just feel a give, and it just glides in that layer. You'll see that. So wait for that to happen. You see the resistance now, and then it goes. After this, it moves very smoothly once it's in that layer. And Duas layer is quite resilient, so it's not really going to rupture so easily. Now I'm trying to inject air, but the air is coming back through this track. So nothing to worry. You know that you've reached the correct space. So anything you put into that channel will go into the correct space. So I decided to use viscoelastic instead. So I'm just using HPMC now through the normal viscoelastic cannula, which is quite large actually. And you can see that you get the very similar appearance as a big bubble. This is a visco bubble. And you just keep injecting till you reach the edges of your trephination. This is what they call the type 1 bubble. A type 1 bubble will not go beyond 8.5 millimeters or so. And then of course you remove your quadrants, as was shown very elegantly by Dr. Vanti. Rest of it is quite simple. You just mount your donor cornea on an artificial antechamber and take it off, and you get the same mushroom cut. Take off your desmes and put it in the donor bed and recipient bed and suture it. This was already alluded to. You can use deep lamellar keratoplasty for advanced infectious keratitis. I personally don't prefer for fungal keratitis because we know fungus can penetrate intact desmes membrane, and penetration of antifungal drops is not so great. So I'd rather just remove everything. But for advanced Canthamoeba and even bacterial keratitis, this is a great idea. Bacterial keratitis, I'd use it only when the thinning is very advanced. Otherwise, we know that medical treatment often works very well. So this is just to show representative pictures of one case, and you can see how nicely DALC works, and probably a penetrating keratoplasty would not have given such a good result. You can also combine deep lamellar keratoplasty with surface procedures like the CLET here, cultivated limbal epithelial transplantation, and advanced stem cell deficiency with scarring, and you can get a very good result. Some challenges that you can encounter in DALC. This is a patient where you're trying to get a bubble, but you get an emphysema. So you're not really sure whether beneath all that emphysema you do have indeed something. But if you remove a layer, you'll be able to see, and you can see that small bubble test which Dr. Vanti showed us, which confirms that it's a big bubble. And you can just put in a needle into this bubble and enlarge it to the desired size. So you don't have to enter the bubble, you just be in the stroma there and just inject some more, and the bubble will enlarge quite nicely. Sometimes if you have a cataract along with corneal opacity or ectasia, you can combine the two. You can do dissection of the stroma and do the phaco and then go back and put your donor button. In this particular case, we have gone down to the Duas layer and we're doing the phaco with that, but perhaps this is not such a good idea because the layer is very thin, it may rupture with the pressure in the anterior chamber. So now what I would do is do a lamellar keratectomy, enough to see, then do the phaco, and then complete my dissection and then do the suturing. So this particular case I want to show you, I punctured the bubble but too aggressive and then end up puncturing the Descemet's membrane. So perforation is not the end of story for DALC. Most perforations can be salvaged. It's only about 5% that will need conversion. So in this case, we just put in an air bubble and then we sutured the center, completed the dissection from the periphery, and then in the center just put a small drop of fibrin glue, put a patch of stroma, and then we could form the anterior chamber with air. And then after we put the button and put a few sutures, you can see in the right video, I actually pulled out that little patch. Luckily, the fibrin glue didn't hold so well, and I could tease it out. If it's eccentric, you could even leave that island there. Because it was in the center, I decided to remove it. Again, here you can see this is a manual dissection, the same technique. This was a patient with old hydrops. Perhaps not a good idea in this kind of a case. You get a perforation, but if you manage it well, you can see that perforation triangular one there, but still patient gets a very good result. The final video, I know I'm just beyond time, but I thought I should show you a type 2 bubble since it was alluded to. So this case, just see that emphysema, then you see this little glassy bubble. That's called a type 2 bubble. This is actually between the Descemet's membrane and the Duas layer. So a problem with this is it's often eccentric and it may not extend to your trephination mark entirely. What I wanted to show you in that video is, in spite of that, you can complete your surgery normally, as you can see in this case, but the puncturing of the bubble, you have to be very careful because the deep layer is only Descemet's. It's very, very thin and fragile. It can rupture very easily. So here I was lucky. You see the air comes out in a jiffy, and then you remove the layers as is shown here. This again is very delicate. It just ruptures on touch, unlike the Duas layer. So you have to be very, very gentle, and more often than not you can end up rupturing that layer. So DALC is the gold standard for stromal disease treatment. Although big bubble is preferable, sometimes we may need to do manual techniques, and they are a good alternative, and long-term results are pretty similar actually if you've gone deep enough. Most challenging situations in DALC can be overcome to complete a successful DALC. Thank you.